Again, good morning, everyone. Thank you for joining us. Today is a very special guest that we have with us this morning, Dr. Jahromi. It's a very special guest for me as well. Dr. Jahromi was my mentor during my residency at Northwestern. So when I was in the trenches, getting beaten every day in residency, he was always very supportive, and I think he's to this day. I think he's always been a huge advocate for residents, for education. So I'm very excited to have him on today and to have him share with us some pearls of wisdom in his world of intracranial hemorrhages. Dr. Jerome is a dual trained neurosurgeon specializing in endovascular and cerebrovascular surgery with fellowships from University of Miami and Buffalo. And for those of you who know these are the motherships for open vascular and endovascular neurosurgery. He also has a PhD from University of Chicago. He currently serves as the vice chair for regional neurosurgery at Northwestern Medicine. His clinical and research interests include stroke, carotid stenosis, cerebral aneurysms, subarachnoid hemorrhages, trigeminal neuralgia, and he has over 300 papers, abstracts, and book chapters published today. I can speak about his accomplishments for 15 minutes, but I think that's a better it's time better spent listening to his talk. Thank you, Dr. Jahromi.
It's really a wonderful pleasure to be here. Thank you very much for the invite. It's always a great pleasure to see one's superstar residents go on and become accomplished faculty. And so, really, I can't tell you how proud Northwestern is of your accomplishments and how you've expanded the cerebrovascular field. So, thank you very much. I will try to go over what I still think is a very old disease, yet in today's world an emerging disease yet again. And then hopefully we'll have maybe about 10-ish minutes, 10 to 15 minutes for questions at the end. All right, so we'll get started. Here are a couple of disclaimers, and then just to sort of set the stage, this slide is not going to come as any surprise to anybody here, right? Stroke is a big disease. It has a lot it has a lot of morbidity and mortality, and most importantly, it's very expensive, right? And these are, numbers from 10 years ago. So anything we can do to adjust and improve our therapy for stroke is super important. Now, I'm going to draw your attention to this pie chart, right? And, ischemic stroke, which is the biggest side of stroke, gets most of the press. However, I'm going to put it to you that by and large, while it is a bad disease process, we've made tremendous strides in ischemic stroke, right? We've gone from TPA to the old Mercy device now to thrombectomy, to a point where right now, by and large, stroke has a very well-regulated algorithm, excellent devices, and pretty well-established treatment to a point where advances in stroke may have even plateaued. We're getting better catheters and faster suction aspiration and so on. But you could, from a procedural point, almost say we've checked off that box. We now know how to treat stroke very well, very efficiently, and our outcomes are much better versus, say, 20 years ago. For subarachnoid hemorrhage, ruptured aneurysms, again, outcomes are substantially better than, let's say, 30, 40 years ago. We've gone from clipping to adding, traditional coiling to now we have flow diversion intrasaccular devices. So really, all of the advances now are beginning to be incremental. We really have good tools in the toolkit. So in this pie chart, right, you can put a checkbox on ischemic to some extent. You can put a checkbox on subarachnoid hemorrhage. And then you're into this red sliver, red deliberately because it's hemorrhage. And not much has changed since I was a resident. And I'm embarrassingly, I'm going to tell you not when that was, but we're not doing things that differently. There's not dramatic standards of care that have shifted. We have better neurointensive care. We have a more aggressive approach. But I'm going to put it to you that if you're interested in stroke and you really want to make an advance, the place to really put your efforts now is in this remaining 10% where therapy lags behind the other aspects. I'll prove it to you. Here's data. So subarachnoid hemorrhage is to some extent near and dear to most neurosurgeons, certainly to vascular neurosurgeons. And many of us back in the day became attracted to this field by seeing patients devastated by subarachnoid hemorrhage and seeing how the treatments were technically challenging and elegant. And so it appealed to us to be able to help somebody who was very sick with advances that could really help. All right, so let's look at mortality for subarachnoid hemorrhage. Here is over the past, around 1990s to 2018. Everybody can get this data online. And so mortality from subarachnoid hemorrhage probably hasn't shifted a heck of a lot. But look at mortality from ICH. It's a lot worse than subarachnoid hemorrhage, both in impact, right, and in rate. And if you don't care about mortality, you'd say, well, all right, they're dead. There's nothing I can do about it. A pretty morbid way of looking at it. What about the quality of life? And there's a way of looking at this. It's called DALYs, daily adjusted life years, right? So this is how you account for it. Healthy life, and then you end up having the loss of equivalent of 1 year of full health. So the way you account for it is look at all the years you've lived because of premature mortality and all the years lived with disability. And you add that up and you get a daily. And so here's subarachnoid hemorrhage, well known to neurosurgeons. We have all these endovascular and vascular neurosurgeons interested in subarachnoid hemorrhage. There's your DALYs, 176. Look at ICH. A lot worse. Yet it doesn't get the publicity, it doesn't get the interest, it doesn't get the trials, it doesn't get the research. And so I would put it to you, if as surgeons, as critical care specialists, as neurologists, we have this vast interest in subarachnoid hemorrhage, we should be even more interested in cerebral hemorrhage, right? It's higher mortality, higher loss of functional ability. And at this point, by and large, most folks stick for medical management. So if we care about subarachnoid hemorrhage, we should care more about ICH. So I want to plant the seed that we should not neglect this. We have to do something better than what we've historically done. All right, now just reminding everyone, the rest of this talk is going to be about intracerebral hemorrhage. So I'm going to put aside all the other forms of hemorrhagic stroke. We're going to focus primarily on ICH and primarily on non-lesional ICH. So intracerebral hemorrhage, not from AVMs or aneurysms or tumor, good old-fashioned intraparenchymal or deep hemorrhages from, frankly, hypertension. That's the worst cause. So we're going to focus on that. Rewinding back to Broderick's seminal stroke studies in 1993, where they got the Oxford Handicap Scale all the way to a Hemphill stroke paper. It's a bad disease. While it's only 10% of stroke, the mortality is a lot worse. The incidence is not small. It's worse in minorities. The 30 mortality, as you can see, is 45%. And at 6 months, your chance of being independent are terrible, 1 out of 5. This is the classic Hemphill stroke we all have to know. We put the ICH score in our notes. It's required by a lot of commission guidelines as it has to be tabulated. And you can see the more hemorrhage you get, the more volume you get, the more the mortality goes up. And historically, this is why most of us were fairly nihilistic. You started getting to an ICH score of 3 and you're hitting 70 to 80% mortality. And so it was another reason, almost a self-fulfilling prophecy, that somebody would come in with a hemorrhage and you sort of shrug your shoulder. You'd say, well, they're going to die anyways, and I have nothing to offer, and you'd walk off. Now, as time has passed, right, this score is being proven to be rather premature. So here's modern data. This is a paper that came out not quite 10 years ago. And this is with aggressive management. And take a look. This is what the Hemphill score would predict. And with aggressive management, particularly in ICH 3 and 4, it's not all death and destruction, right? Hemphill would have predicted 70% mortality. You can reduce it to less than 50%. For ICH score of 4, you are dead with Hemphill score. You still have a chance with more aggressive modern treatment. And so increasingly, we're believing that our prior beliefs were a bit too pessimistic. This is American data. This is Canadian data from the Montreal Neurological Institute in 2023, so more recently. And again, score for score, particularly take a look at a 3 and 4, you can improve upon what Hemphill would have predicted with aggressive care. And most recently, if you take the data coming out of the MISTY trial, which looked at patients with severe ICH and intraventricular hemorrhage, right? When they first show up, they look terrible. Now, we're all used to thinking, all right, let's look at day 30 outcomes. By day 30, they still look terrible, right? Your modified Rankin scores in outcome in patients with severe IVH and ICH is very poor at day 30. So one has to be far more patient for these, no pun intended, patients. By 6 months is when you're beginning to see recovery. Take a look. By 6 months, you're getting MRs of 2 and 3. These are the walkie-talkies. You still get continued improvement by 1 year, right? So if you are willing to nurse these patients and grit your teeth and get the family through and get the patient through what is a terrible, long process, by 1 year, 40%, think about that number, almost half of patients with severe ICH and IVH are going to have a good outcome, right? The walkie-talkies, the independent ambulators. This is a huge deal. So I think we have to remember that while these patients look terrible, and they're going to look terrible in the hospital, right? They're never going to get better in the hospital. You're going to ship them to a SNF, or if you're lucky, a reasonable rehab. You have to just steel yourself and wait for 6 to 12 months for the sun to rise on the horizon. And so we have to readjust our expectations, right? This is not ischemic stroke and you go in and you suck a clot out and like the Lazarus effect. You get off the angio suite and thank you very much and buy a gift card the next day. It's not going to happen. So if you're going to be an ICH, you must be patient, but it is absolutely worth it to get them past 6 to 12 months. That's, I think, the most important message to leave behind. Now, at this point, the guidelines emphasize that while we may use the baseline severity score, it should not be used as a sole basis for prognosticating patients. So don't use the HEMHIL score to make a decision. It's not appropriate. All right, so now what can we do? I'm going to go over these following points. So I'm going to show you the medical trials, and by and large, I'm going to tell you that most medical treatments seem to have marginal benefit. We have to do them, but they haven't shifted the benefit much, except the most recent Interact-3 trial. So that's a key trial we have to know about. That's on the medical side. I'm going to talk about the surgical side. So I'm going to go over the history. By and large, the message I'm going to leave you is that big open surgery improved mortality, but didn't seem to do anything for functional improvement, with, again, a recent exception, which is the switch trial. And then finally, I'm going to talk about minimally invasive trials. And again, most have shown minimal to no marginal benefit. They have improved mortality, with, again, an exception, the enriched trial. So as you can see, we're beginning to now, both on the medical, the surgical, and the MIS trials, see trials surfacing up that are selecting the right population and the right therapy for these patients. Nevertheless, we have to get better, and then I'll set the stage for why I think you should participate in your trials. All right, so very quick, this is almost a history lesson. This is Stitch 2. It's probably the most widely quoted and misquoted trial out there. This was, burnt into a lot of brains back in residency, and it was the primary reason that, the junior neurosurgery resident walked to the ED, say, nothing to do, and walk away. And it has haunted our field, unfortunately, because it is incredibly misinterpreted. Nevertheless, this trial was used by a fair amount of neurosurgeons to say there's nothing to do with ICH, don't call me, send it to ICU, and it's not my problem. So I need to demystify this trial. Stitch 2 was a trial looking at lobar ICH. So first of all, Stitch 2 tells us nothing about basal ganglia or thalamic hemorrhage. So you cannot use, as a surgeon, as a proceduralist, Stitch 2 to say anything about basal ganglia or thalamic hemorrhage. This just doesn't apply, right? That big basal ganglia hemorrhage will come in, you say, Stitch 2 didn't help. These didn't go into Stitch 2. It doesn't apply it. It was a very select population, right? Specifically, the GCS had to be, M over 4, E over 1, not comatose. And it was not a trial of surgery versus medical therapy. This is extremely important. It was a trial of early surgery versus deferred surgery if necessary. So I'll show you what it showed. It showed that early surgery versus an initial conservative therapy with deferred surgery if needed had a near significant improvement in mortality. Having said that, it did not improve functional disability. So early surgery, while it reduced mortality, it expanded the upper severe disability. And for this primary reason, most of us said, well, fine, people are going to live, but they're going to live severely disabled. What's the point of offering this? Okay. Now, the issue is this is not surgery versus no surgery. It was a trial of early surgery versus initially sitting on the patient and then operating if they got worse. So you cannot even use Stitch 2 to say you should never operate. If somebody comes in with a big parenchymal hemorrhage and they're deteriorating, Stitch 2 says you need to operate because that was the other arm, all right? So need to demystify that. Now, people have actually gone back and reanalyzed Stitch 1, Stitch 2, and Stitch trauma. They put them all together. Long and short of it, it turned out that we're probably operating on the wrong group. It's kind of like, Goldilocks and the Three Bears, it's too hot, too cold, and just right. So it turns out operating on somebody with GCS of 14 and 15 is probably not a good idea because they're too good. And then operating on somebody who's really bad, and again, this is really retrospective analysis, so you have to take it with a grain of salt. But bottom line, there's a group that's too bad and it didn't help. But there was a sweet spot in between, patients who were harmed, but not harmed enough to not benefit. And so that is the first indication that there's probably people who are too bad for surgery, there's people who are too good for surgery, but there's going to be a large portion in between that we can and should help. All right, so keep that in mind because the remainder of the trials are really not trying to cherry pick who's the right person and who's not. Think of it like the thrombectomy trials, where initially try to find out who are the right candidates based on core, penumbra, and so on. So we're kind of in that phase for intercerebral hemorrhage. All right, so it turns out that it's probably true that the reason Stitch was not positive is some patients weren't benefiting because they were too good, and some were going to get harmed because they didn't need surgery. All right. So, nevertheless, at this point, in general, open craniotomy is less favored for intracerebral hemorrhage. Now, what about not doing an open craniotomy, right? Just a decompressive hemicraniectomy. Interestingly, this trial just came out, 2024 online. And so they do look at the deep hemorrhages. Remember, Stitch was looking at superficial. Stitch was looking at superficial. Stitch looks at deep hemorrhages. So basal ganglia thalamus. These are patients that are affected. The GCS 8 to 13, the NIHSS is significant, so they're not a minor deficit, and the volume is not small. It's at least 30 to 100 cc's. Surgery had to be within 72 hours. Unfortunately, it got stopped too early, right, due to lack of funding. But what's interesting is that it did make a difference in decreasing the number of patients that hit MRS of 5 to 6 at 6 months. So at this point, there's weak evidence that if one does do decompressive hemicraniectomy, you'll certainly improve mortality and have some improvement in functional disability. So in a jam, you've got a big basal ganglia hemorrhage, you're not comfortable evacuating it. It's not at this point unreasonable to do decompressive hemicraniectomy. I'm going to show you better ways of treating it, but there's at least one open surgical trial that has shown positivity for deep hemorrhages. So keep that in mind. Here is the functional benefit. So this is at 180 days and 365 days. You're used to seeing these kind of shifts in the MRS score. And again, you can see that not only is mortality reduced, functional benefit is also achieved. So this is the first trial using big, large, open craniotomy to show that it actually does have a benefit in deep basal ganglia hemorrhage. All right. So all trials have not particularly been robust except Switch. Switch does provide weak evidence with functional benefit for deep basal ganglia hemorrhage. So one trial so far. All right, so that's the surgical aspect. What about the medical trials? And I'm going to go very quickly through these, okay? So you would think somebody comes in, right? They've got bleeding in the head. This is an extrapolation of other trials, bleeding in the body, trauma, et cetera, et cetera. Get them in quickly within 8 hours and give them, tranexamic acid. You would think giving a procoagulant at least within 8 hours would do something. And sadly, it does nothing. So TXA is out. You should not be giving TXA for intercerebral hemorrhage. Okay, what about other procoagulants? There was a lot of hope put into recombinant factor 7A. The phase 1 and phase 2 trials were actually positive. And this was super fast, right? It was within 4 hours, and they waited 3 months to assess the outcome. Unfortunately, didn't work. Now, there was probably some underlying issues. There was more intraventricular hemorrhage in the treatment group, so maybe that skewed the results. But unfortunately, it's unlikely anybody's going to go back and try this specific trial. It's now been advanced to look at the FAST test trial, which is trying to give this within 2.5 hours of intracerebral hemorrhage. That trial actually just came out. I apologize, I don't have the slide for that. Fastest just got published, and it turns out that even if you give it ultra fast within 2 to 3 hours of patient arriving in the ED, it doesn't work for all patients. There was a signal that it would work in patients with a CTA spot sign. So the population that's even eligible for recombinant factor 7A is going to be even ridiculously more smaller, right? It's people that show up from ictus to in your ED within 2-ish hours who have a CTA positive sign. And so it's actually hard to find the patients to randomize for this, unless you've got a mobile stroke unit. So again, while this may have a role in the future in a very small minority of ultra acute hemorrhages, I suspect it's not going to do much. All right. What about platelets, right? You come in, you're on aspirin and Plavix, and you've got a big bleed. You would think Makes sense. Let's at least give them some platelets run, the platelets are poisoned. And I remember as a resident, patient would come in with a hemorrhage and you'd hang one or two super packs thinking you were doing good, right? It made sense. Well, not everything that makes sense pans out in a clinical trial. And it turns out platelets actually make things worse. So if somebody comes in, they've had aspirin or Plavix and they've got intracerebral hemorrhage, unless you're operating, that's a whole other story. Medical management, you don't give platelets. That's a significant change in my years as an attending. Now, if you're going to put an EVD or if you're going to put in craniotomy, it's reasonable to give platelets. But if you're not doing invasive therapy, platelets also don't work. All right, we're in trouble. Boy, anticoagulants haven't worked. Platelets don't work. What about blood pressure? Okay, let's see if we can control blood pressure real quick. So we're going to give them Cardine within 4.5 hours, right? We're going to go hardcore. We're going to super fast drop the blood pressure with intensive therapy, and doesn't do much. This is incredible, right? And we're doing all these things, barely a change in functional outcome. All right, so what if we do everything? We're going to throw the kitchen sink at the patient in the ICU, right? We're not going to just do blood pressure. We're going to do a care bundle. We're going to go for early intensive treatment of systolic blood pressure, strict glucose control, antipyrexia, rapid reversal warfarin, everything under the sun, right? Diastolic blood pressure, glucose, temperature, systolic blood pressure. This represents the height of neurocritical care in today's world, right? An absolute delta of 5%. It's now 2026. Centuries have passed in this disease process. This is where we are, 5%. All of our efforts, we're shifting the needle, 5%. So when this data hits you in the face, you think, oh my God, we have to do more research. So we can't just sit on this, right? This is just embarrassing. Look at all the progress made in ischemic stroke. Look at all the progress made in subarachnoid hemorrhage. This is what we're doing for intracerebral hemorrhage. This is not acceptable. And so it's data like this, and it's, really the bad outcomes we still get for intracerebral hemorrhage, now in, my mid to late 50s as a older surgeon, and we're still here. How this is just not acceptable. So my pitch to you is this is a disease process that absolutely requires every one of us to still work hard and find better therapies. Okay, so what could we do? Well, craniotomy is not cutting it, right? Open craniotomy with tissue trauma didn't seem to help, although the subsequent analysis makes some suggestion, but still. Okay, decompressive hemicraniectomy, well, it improves function, but that was for basal ganglion hemorrhages. It was a premature trial. And to be honest, there still has to be better ways. What about all the medical treatments? Well, procoagulants doesn't seem to work. Blood pressure control, marginal, unless it's part of a very large care package. But even then, the thresholds of timing is not fully defined, but at least medically, we have to do that. Not just BP, everything else. All right, well, this doesn't look very appealing, so we have to do something better, all right? So what are our options? Well, this is, to not make fun of Star Trek, the final frontier. This is the next step. And here are all the trials, all the devices, and really they're all working through a fairly small hole, from the craniopuncture that's widely used in China goes through a hole that's about 3 millimeters to even the Enrich Endoport, which is again, right, 15 millimeters. That's still about, half an inch or so. So we're gearing to do things now through smaller incisions, smaller access, less disruption of normal brain, and we're trying to see if these will now finally make a difference. Okay, so where are we? Well, minimally invasive evacuation is not something new. Even before it was tried by the Hanley group in 2016, 10 or 20 years before that, people were trying it. This is probably the more modern first attempt at doing it, looking at, hematoma volumes that were 20 cc's or bigger. This tends to be the cutoff now in most trials. And symptoms had to be under 12 hours before they were put into the trial, surgery within 48 hours. Fairly modern, right? This is how most minimally invasive trials are now done. And it turns out that it was very effective, right? They took, on average, between 60 to 80% of the clots was removed. So the technique works. And this really kills me, right? This was published in Stroke in 2016, 10 years ago. It was a dramatic improvement in functional outcome. And remember, they went up to 1 year to follow these patients, okay? And so a substantial improvement in good MRS. They were looking at MRS of 0 to 3. Again, the walkie-talkies, independent ambulation, right? And so you could double the proportion of such patients from 23 to 42%. The worst part is it just wasn't enough patients. The p-value is 0.19. But this should have caught on. And well, I wish we had done more patients and more trials at that point, but it didn't. Nevertheless, it's a big signal that there is a way to improve patients consistently and improve them not just on the mortality side, but functional outcome. All right. More of MISTY, though, wasn't endoscopic. It was putting an EVD into the hemorrhage. This was, very well educated. You had to do it with neuronavigation. You would have to go on a track down the long axis to the hematoma. So this is us doing one of these cases. It's a very small incision. It's a teeny hole. Using neuronavigation to go down, put a small little peel away sheath, suck out as much hemorrhage as you can immediately with a 10 cc syringe, leave an EVD in, and then over the next 3 days, every day you'd put a little bit of TPA, it would dissolve the clot, and it would slowly leak out into a bag. And when it worked, it would work surprisingly well. So we were actually one of the bigger enrolling centers in the Midwest. And, I was hoping this would work because it was really easy, right? You go to the OR, put an EVD in, the rest was in the ICU, and all right, looks impressive. Unfortunately, a trial that we were all hoping would show a good outcome was basically a wash. And this was very well educated. The trial leaders would actually call you, look at your scans, walk you through the procedure. Like the surgery was very well overlooked. It turns out that it can certainly reduce mortality, but the functional outcome we care about, MRS 0 to 3, did not budge. And this is going all the way out, even to 1 year. So we waited patiently to see what happened with these patients. Now, what is interesting is the subgroup analysis. It turns out that perhaps this technique isn't effective for everybody. And so in about half of the patients that were treated, you could not get the hematoma under 15 cc's. And about half the patients you did treat, the hematoma was under 15 cc's. So if you could somehow get past that threshold, you actually had a dramatic functional improvement. Actually quantified that. So this is the end of treatment ICH volume. And you can see this is the probability of MRS of 0 to 3. So as you have less and less residual hematoma, right? Not much. It's getting better and better. Then finally, at that 15 cc threshold, things to get a lot better. Or if you look at percent hematoma removed, if you can get over about 70, 75% hematoma removed, your outcomes become much better. So it turns out that it's probably an issue of the surgical technique. If you can get blood out of the head, you're going to do well. The problem is, how do you consistently, in a minimally invasive method, get the blood out of the head? And so MISTY is a seminal trial, not because it was positive, but because it taught us that, yes, there is hope. And yes, the issue isn't whether we should do something. The issue is we should do something better. We need a more consistent way of getting blood out of the head. But if you do get blood out of the head, you will improve these patients' outcomes. All right. So it was the first trial to show for MIS, there is a survival benefit. There's a functional benefit if you can get the residual volume under 15 cc's. This is now burnt into everybody's brain. It didn't change length of stay, etc., but it was also very safe. Nobody was harmed. If you looked at the treatment versus the observation group, there was no disadvantage to getting this treatment. And it's an easy thing to do, very familiar to surgeons, right? All of us know how to do a neuronav. In fact, you can do this these days in the CT scan room and not go to the OR. Okay, let's go the other extreme. What if we do a mini craniotomy and then use one of these Endoport devices, a Vicor tube or something like that? And so this does require a little bit of a larger hole, dura opening, and a small corticectomy to get this tube in. And ideally, you want to go down a pathway or down a transsulcal pathway, but generally, the way it works is you find the most direct path along the long axis of the hematoma to get in. This is from Gustavo Padilla, the PI of Enrich trial, and this is how it works. So you've got a mini craniotomy, you open the dura, you're going to open the arachnoid, and then you're going to open a teeny corticectomy down the sulcus. You're going to put this for neuronavigation. Remember, look at how huge those fingers are. So this is actually a very small tube, right? And now you can actually work down that path with instruments you're used to, right? You bring a microscope, a suction, a patty, you can evacuate a hematoma, you can really gently move that port around to look around. And then if there's a bleeder, right, you can get a bipolar and actually bipolar it. So, well, it's working down a tube. The tools are very familiar to surgeons. And so it's not that hard to teach and it's not that hard to adopt. And you can certainly evacuate quite a bit of that hematoma, as you can see over here. So familiar tools, familiar techniques. And then you can go around, make sure that this cavity is hemostatic, put a bit of Surgicel. So all of these are very, very familiar techniques to surgeons. So the learning curve for this is not that steep. And then you very gently take it out. Make sure that you've not hurt nothing along the path. And there you are. So MIS access, put a piece of gel foam, close up, and there you go. Okay, so this trial was successful. The challenge is, let's say with 11,000 patients, they randomized only 300. So 11,000 they screened, only 300 were eligible to get into the trial. And the challenge is that a fair number of them had secondary, not primary ICH, right? That trauma, aneurysm, AVM, moya moya, something or the other. And more importantly, they excluded thalamic or infratentorial hemorrhages. So this trial is only positive for supratentorial lobar hematomas. Okay, and it has to be primary ICH, and the volume has to be just right. If it's too small, under 30, or if it's too big, over 40, over 80, they did not randomize these patients. And then if the patients are too sick, remember we said this right at the beginning, if they're too sick, GCS under 5, or if they're too good, GCS over 14, or if the inertia it's just too good, you don't treat them. So there's a lot of inclusions, exclusions, but bottom line, you need a primary ICH that's supratentorial, that's not thalamic or basal ganglia, that is between 30 to 80, and GCS is between, higher than 5 or lower than 14, then they're eligible for this. When they are, it turns out that you do have improvement, not just in mortality, but the entire MRS score shifts over. You've seen these kind of data for ischemic stroke. Here's the same kind of shift in MRS for hemorrhagic stroke, and it does work. However, it turns out it works for lobar. The entire trial, the pooled trial, was positive for treatment effect, but if you split it between lobar and anterior basal ganglia, lobar is very effective. Anterior basal ganglia, it's a wash. And so they had an adaptive trial design, and they actually ended up dropping the basal ganglia hemorrhages about midway into the trial. So at this point, we now have an MIS trial. It has functional benefit for decreased mortality, improved function, decreased ICU length of stay, decreased hospital length of stay, et cetera, for lobar hemorrhages, not for basal ganglia. This really is now becoming standard of care. I suspect it's going to be in the HA guidelines. So at this point, if you do have somebody that does fit enriched criteria, right? It's a phase 3 RCT in the New England Journal of Medicine. I think you're obligated to at least consider offering this for somebody who fits it. The technique is also reasonably similar, right? It's your traditional microscope, suction, bipolar, and endoport, not hard to adapt. All right, now, the redheaded stepchild still remains that deep hemorrhage, right? What do we do for that? Well, it seems the endoport, the Intracranial style, doesn't work. What about minimally invasive endoscopic access? And so this is through a very small 14 millimeter burr hole. You put a 19 French sheath, and through that, this is one of the devices you can use through an endoscope, and there are other devices that are all commercially available to basically macerate the clot, aspirate the clot, and get it out. So I'm going to just quickly go through this. This is an example, a cartoon example of how this would work. So you find the long axis of the hematoma, put an endoscope down that path. Inside the endoscope, you can use tools such as aspiration, suction, monopolar, bipolar, clot macerators, clot evacuations. And so you basically, evacuate some of the clot. This is not a perfect cartoon. You actually start irrigating and creating a cavity, and then you walk around, look at the cavity, see if there's any bleeders, and then you take it out. And the cavity never collapses like this cartoon. It just stays as is. It takes a long time for this to happen, but it looks good in the cartoon. Here's what it looks like in real life. So you're irrigating constantly. And now you can see in a minute, there's the aspiration tool. You grab a piece of hematoma and boom, there's white matter underneath it. So stop. You don't have to take a lot more. You take very gentle bites here, right? This is hugely expanded. And then as you're looking around for hematoma, you see a little blood vessel like this. And no, leave it alone. So the enemy of good is better. So it's okay to teeve a teeny blood clot, but you don't want to start bleeding by taking out teeny blood vessels. And it's amazing how well you can see them, right? You're working at very, very fine scale. And so you can find small bleeders, avoid getting to small blood vessels. It's a very, very delicate technique, but you have to be patient, right? You have to just take your time and go slow. That's what it looks like. This was the MIND trial. Again, it was halted in 2023 prematurely because Enrich came out. And when Enrich came out, in good conscience, the trial could no longer randomize the lower hematomas. the DSMB looked at the trial and said, look, if you're going to only randomize vasoganglial hematomas, you're not going to hit a statistically significant value within the amount of time and effort required. You need a lot more patients. So the trial was halted. And here's what it showed. So it turns out that at 30 days, if you do endoscopic evacuation, the surgical group does vastly better than the medical group. So I want your attention on this side, right? Here is improvement in functional outcome, MRS of 0 to 3. And look, odds ratio 4.2. At 30 days, mind endoscopic evacuation was even better than enrich. The challenge is that in this group of patients, the medical recovery does occur. So by 90 days, while the trend favored endoscopic evacuation, it crossed 1. For enrich, it didn't. And at 180 days, it still favored endoscopic, but for Endoport, it still didn't cross 1. So what this shows is that while the odds of favorable outcome were much better at 30 days, it wasn't significant at 90 at 180 days, although the trend persisted. And so that's consistent with enrich, but not statistically significant, but certainly very much raises the flag as to, okay, how can we do this better? In particular, it turns out that it also has better trends in length of stay. It has better trends in the ICU stay, and it was absolutely safe. No one was harmed. There were actually more adverse serious effects in the medical group than in the surgical group. So what do we know from MIND now? Well, it does show functional benefit, but only at 30 days, not at 180 days. It's absolutely safe. You're not harming people. And there's a trend towards decreasing LOS. There's going to be more papers coming out of this, so I'm not going to get into that. And the technique is endoscopic. It's familiar to some neurosurgeons, not all. There's a learning curve, but it's certainly something that most of us can pick up and do. All right, so where are we now with all of the MIS trials? Okay, and the MIS trials are the craniopuncture, then in China, the MISTY trial, that's putting the EVD down the track, the ENRICH trial, which is the Endoport, and then the MIND trial, which is the endoscopic trial that I showed you. Well, the ENRICH, MIND, and MISTY trials are actually fairly the same, right? They're all looking at like 20 to 30 cc or more volume. Most of them had a cutoff at 80. MISTY didn't have a cutoff, but it's rare that you had something bigger than 80. They were all generally looking at patients between, 1 to 3 days, except ENRICH. Keep this in mind. ENRICH was the one trial that demanded you do surgery early, under 24 hours. So there's a suspicion that maybe that's why these patients did better versus MIND and MISTY were neutral. So maybe we should be doing this surgery faster. The outcomes at the end, by and large, were roughly the same outcome measures. And in the end, they by and large assessed it the same way, right? Looking at MRS or utility weighted MRS, et cetera, et cetera. What did come out is from ENRICH, there was benefit. So that's a positive trial, but only in lobar. In MIND, there were trends, but not significant at 6 months. And then in MISTY, we do realize that you got to get the clot under 15. So all of these trials now are informing our current and future practice. All right. I mentioned the time part that maybe that helped enrich, and we do think it did. So Chris Kellner and his team and Jay Maka did a great job of looking at all of their data from Mount Sinai, and they think there's a time response curve where if you can get the procedure done early enough, ideally under 24 or perhaps under 18 hours, you're going to hit the margin of benefit. And keep that number in mind because that's going to come out in the more upcoming trials. The one thing that I do want to remember, we're talking a lot about ENRICH and MIND and MISTY. In one of the biggest countries in the world, China, they've shrugged their shoulders. They did this trial back in 2009. It's a craniopuncture. And they found that with just a craniopuncture, you basically, in the CT scan room, drill a small hole, and even without neuronav, like in serial scans of CTs, you put one of these small little catheters down, you put urokinase down and a bag into it, every day, and a bag to hang out. Very easy to do. And they found that they had a significant improvement of patients who were better and a decrease in dependent patients. So by and large, this is now standard of care in China. You come in, you have a hemorrhage, you're going to get this, and in their hands, it seems to work. So we should also be aware that we're still doing these trials in North America and Europe, but not necessarily is this, an issue in a lot of countries in the Eastern Far East. Craniopuncture is now just taking over. All right, so what are the new technologies? Well, you saw that Endoport and you're putting a microscope down it and et cetera, et cetera. Some people have said, well, why do you need all this fancy stuff? Why don't we just put kind of mix the concept of endoscope and an endoport, we'll have this new tube, which is like the Enrich Vicor tube, but it's going to have a camera and it's going to have the illumination directly into it. Easier to see, faster to incorporate. You don't have to bring an endoscope. You just hook it up to the TV monitor and you're good to go. And then down that, you put this surgiscope device. So it has a larger and a smaller tube, and then they have their own version of an evacuator that has, suction, maceration, aspiration, the tip of it, etc. And this has been used. This is one of the Mark Bain's papers from Cleveland Clinic. This is him doing this surgery through a small tube. And yes, you can absolutely take a large basal ganglia hemorrhages with minimal residual. So this is now a new device. There's a couple of trials coming on this that I'll discuss in a minute. People are now jumping in. Why don't we do an all-in-one endoscope, right? We'll have this as a disposable endoscope that can aspirate. It has a built-in bipolar. It has a built-in irrigation, suction, camera, everything, et cetera, et cetera. So industry is now beginning to jump onto this. Thank God they're interested as to, okay, there is hope in the horizon. Let's see if we can provide surgeons with better tools, and eventually these tools will be incorporated into trials. So think of, ischemic stroke back in the day where we're trying, anything in the kitchen sink, and then finally a company, Concentric Medical, came out with a Mercy retriever, and eventually the stent retrievers came out, and eventually the big aspiration catheters came out, and all this required industry to improve sequentially on the devices until we have the tools we needed to treat it safely. And finally, this is happening in intracerebral hemorrhage. And then one other thing that I should mention is you may have seen there's an irrigating catheter called the Iroflow. It's just like an EVD. People have thought, well, look, Misty was just manual injection of TP and they would just sit on it. What if we just irrigate the catheter with an EVD? So this is just a couple of case reports. This has not been tried, but it's also an interesting concept. You could put this device at the bedside and then hook it up to a computer-controlled infusion. I don't know if you guys have used Airflow or not. It's basically glorified EVD, but that has two ports, not one. You can infuse in one port and then let it wash out on the other port. It has really great uses, but that's a whole other talk in a few minutes, actually. But you can wash out a hemorrhage with this. So maybe we can almost go back to the Misty style treatment if we have a more effective tool that can wash out the hematoma with, low dose TPA. All right. So these are all now the new options. Where are they? Where we're retrying endoscopic evacuation. This is the Dutch trial called DIST. I do need to update this slide. This is back in September 2025, where they had about 230 patients. This is within 8 hours. So it's taking everything that mine did in appropriate patients, but going ultra, ultra early. And remember, the Dutch are the ones that actually published Mr. Clean. They have a way of getting the entire country to do one trial altogether. They're really, really good at it. So they may be the first to give us a sense of, does ultra early endoscopic evacuation work? So they're still enrolling. There is another trial. This is in Australia. They're using the Surgiscope. Remember that device I showed you, which has the camera and illumination all built into the tube? So they're using that. And again, ultra early within 8 hours. So we'll see if that device works super early. And again, the typical, criteria of over 20 cc's, et cetera, et cetera. The eminent ICH trial, this is in Switzerland. They're looking at both lobar or basal ganglia. And again, they're going to go under 24 hours. So kind of like the initial trial, the enriched trial, they're doing endoscopic evacuation. So that's one trial. There is the REACH trial. So the folks who did enrich are now going to do REACH, but this time they're just going to repeat it for basal ganglia. They've tweaked their criteria for patients coming in. So they're going to see if their technique can again be revised to look at basal ganglia hemorrhages. My gut says, I'm not sure that is going to work, right? If enriched didn't show it would work, why would just finessing it work? But at least there's another trial for that. And then finally, there's the MINUTE trial that is now beginning to enroll centers. And again, this is looking at MIND style endoscopic evacuation. And this is going to be ultra early, but two windows. One is going to be under 8 hours. The other one is going to be 8 to 16 hours. And it's going to have an adaptive design. So there's going to be an interim analysis after 100 patients to then see, all right, do both work or do we try to enroll in one versus the other? And it's looking at age 8 to 80, NHS is over 6, so people have at least a reasonable deficit, ICH over 20 cc's, decent premorbid MRS, your classic non-traumatic spontaneous basal ganglia, supratentorial hemorrhages, non-thalamic though. Everybody has found that thalamic hemorrhages just don't recover that well, and also it seems any attempt to do surgery in that area is super high-priced real estate. So at this point, there are no trials addressing thalamic hemorrhages. All right, so we are now at 45, 46 minutes. Excellent. Let's wrap it up. So what I'm hoping to have convinced you that while ICH is less frequent than ischemic stroke, the prevalence is going up, the outcomes are way worse, and more importantly, we haven't done much to advance successfully the field. We've got to do something better, right? I showed you that on the medical side, the procoagulants weren't working. The only remaining trial is fastest, and it's recruiting, but now it's a very small number of patients, right? You have to be within 2 hours in the ED and a CTA spot sign. It is recruiting. The sterolysis, which is putting an EVD down the tract, it has been completed. It was neutral. The post hoc analysis showed that the subgroup under 15 cc's helps. So this is what has informed most of the other surgical trials. So now endoscopic and endoport, we have on the endoport side a positive trial for lobar. We have now recruitment trials for basal ganglia, the evacuate trial and the reach trial. Evacuate is in Australia, reach is in the US. On the endoscopic trials, I showed you 2016 ICs and more recently MIND and JAMA Neurology showed a trend to positivity but wasn't significant. So now there are trials that are recruiting it. DIST is in the Dutch trial. Eminent ICH is in Switzerland, and MINUTE is now recruiting, I should say, starting to recruit in the United States. I did not talk about intraventricular hemorrhage. If we have time or folks are interested, I can put a couple of slides, but maybe we'll leave time for questions. And so we are now looking at a irrigating EVD that we put within the ventricle, the ARCH trial, and we are continuing to recruit. If your center is interested, please let us know. The bottom line I want to emphasize is, though, that these patients are super sick. You've all seen them. So if you're going to get into this, you do have to internally and externally dampen expectations. These are not Hail Mary, yay, I did a thrombectomy, I'm such a hero, look, I got the MCA clot and the patient's walking out. Like, you got to get over your own ego and you have to nurse everybody. You got to tell your ICU, your ED, your neurology colleagues, everyone, this is going to be a long haul. You cannot, prematurely withdraw. If you do endoscopic evacuation and they're, not walking out of the ICU in 3 days, you can't say, that's too bad. Okay, comfort care. Where's the hospice? That's not going to work. If you're going to treat these patients, you got to nurse them to 6 months, preferably a year. It takes that long for them to recover. But I've shown you the data. It's worth it. You can get up to 40% or more good outcomes at 1 year with just the treatment we saw in MISTY. And even that wasn't that, successful over medical therapy, right? So there is hope. We just have to keep being patient, recruiting into trials. Remember, ischemic stroke looked hopeless for years, right? The first set of trials that came out, we all got depressed. We can't do that. This is a trial. This is a disease process that requires us to stay with it. There's a lot of good trials that are recruiting it. There's a lot of signals, there's positivity there. We just have to emphasize these patients are sick. It will take longer to recover, and it's our ethical and moral duty to stick with them and get them to where they need to be. All right, with that, I'm going to thank everybody, wrap up, and leave some room for questions.
Thank you very much. This was a phenomenal talk as expected anyway. But there's a few questions. One that you wrapped up with that, but I'd like to start with that question. Most of our trials in neurosurgery, even with ischemic strokes and all that stuff, it relied on us, just the neurosurgeon in the operating room doing whatever they do, and that's it. And the patient, and then we saw benefit of the patient. The benefits are seen at 30, mostly in 90, even 1 year out. It requires a
Correct.
whole team, and not just a team that's going to be under your
Correct.
control. We have to have an ICU who has buy-in. We have to have a physiatrist and PTOT who have buy-in. We have to have families who have buy-in
That's the
a year
key. You
out.
cannot do early withdrawal, otherwise there's no point. And early withdrawal can hurt these trials. So unlike the old trials where, all right, I did a thrombectomy, do I even need to see him in follow-up? All right, see ya. It's not how this works. So I will drag these patients, right, as the surgeon to my clinic at 3 to 6 months. There's nothing for me to do. The reason I do it, if I don't bring him back, everybody else is going to pull the plug,
Hmm.
right? I'll get a note from, PM&R or SNF, like nothing to do. It's been 30 to 60 days. And so if I don't personally pull them back to clinic and have multiple meetings with the family and show them that your loved one is getting better, they will lose faith. So if
Yeah.
you're going to do this, you've got to shoulder that. Because at the end, nobody's going to care often unless you're the proceduralist who has a personal stake vested in it, or you're the critical care neurologist who helped get that patient enrolled. There's a lot of doom and gloom out there, and we're in America. This is fast food. We want to go to Burger King and stick our head in and get a pass a drive-through craniotomy, right? We're not a
Right.
society that's interested in long-term, thoughtful, meticulous planning and a patient approach, right? We want things now, and so you've got to somehow get over that and emphasize that there is hope, but you have to be patient.
Yeah, that's I think that's a very key point, and thank you for making it. As you know, we have on the line we have a variety of people from neurology to critical care to ED to primary care. So it's important, specifically with the primary cares who are seeing this patient as well, to keep that message going.
Absolutely.
Um, Another question that came in is when making decisions on eligibility for surgical intervention, how does the use of antithrombotics prior to admission factor into the risk-benefit decision making, particularly the use of DAPT or monotherapy with clopidogrel or ticagrelor? Since there's not a direct reversal, and even within an institution, there may be practice variation between individual surgeons.
That's a really good question. So if somebody comes in on, anticoagulants, most can be reversed. I'll tell you, if you do come on anticoagulants and you're giving them, Kcentra and you reverse it, it turns out, from a technical perspective, the clot's a little harder to take out. It becomes really solid. So just when that happens, be prepared to spend more time in the OR. You're going to need more of the maceration tools. It's not going to suck out easily, but fine. If you come in and you're on DAPT, remember I said we don't give platelets unless you're doing surgery. I will give platelets. I will reverse them. The one thing I'll warn you is Brilinta is tricky. So I don't know if I still have that slide somewhere.
Hmm.
I'll briefly share one very quick one if this works. So the audience raises a very good point. Brilinta can be tricky. So this is one patient that came in, and I try to almost never do this. And the initial report from that side of the hospital, we get a lot of transfers. Well, it's a smaller hemorrhage. So this was around 2-ish in the morning. I said, all right, bring it in. We're going to go straight to the OR. And I get a call around 4 a.m. Patient's showing up in the ED, and now things are worse. The scan is much bigger. The pupil's blown. I'm like, okay. And then so we went to the OR, and I thought, all right, I've already set up for endoscopic evacuation. Why don't I give it a shot anyways? And I may not do that again. That was, 4 to 5 very painful hours. So I'll warn you, Brilinta does make it hard. And there were
Hmm.
many times where I was thinking, I should have done a cranie. This is never going to stop. And it took a lot of platelets and a lot of time. But eventually we got it there. But yes, if you do come undapped, we will do it. You have to be more cautious. Brilinta in particular is tricky. I wouldn't do it unless you have had enough, practice at this. Otherwise, consider an endoport rather than endoscopic evacuation. And then if you're doing endoscopic evacuation, the trick is to be patient and you have to have a lot of warm irrigation. So we have like a trauma tower that you would use for, warming up blood. We hang 2 urology, like 10-liter saline bags, and it's all at 40 degrees. And I'll go sometimes through 5 liters over an hour or so of irrigation if it's a really tough case. But you'll find if you just do constant warm irrigation, it buys you a world of hemostasis. So yes, DAPT is an issue. We have surgical ways of adapting to it.
So in your practice, have you went more into the endoscopic or into the endoport, like or the.
Endoscopic,
Okay.
endoscopic. Yeah. It really it is. I mean, it's beyond elegant. I'll give you one other example, and you'll see why. Here is, do you guys see the slide? So
It's
here's a patient that
yes.
came in. This patient declined surgery, right? So here's day one, and this is a young guy, I think in his late 40s, and he already has shift, and internally thinking, I know where this is going to go. Day 8, Lots of edema. Look at that shift, right?
Yeah.
Now he's blowing at people. This is bad. You're going to do, typically decompressive hemicraniectomy. And again, I did the MR. I saw fluid level. I thought, you know what? I'm still going to give endoscopic a shot, right? And, even at that time point, right? The video doesn't work. Okay, who cares? Bottom line. Anyways, take a look. Endoscopic evacuation. You can totally
Yeah.
reduce the hematoma. And then all I have to do is through a teeny hole like this and a small incision. So, I mean, why not? If you're
Yeah.
willing to be patient and evacuate it, at the end of the day, it's much easier for the patient. It's a way smaller incision. You don't have to put a bone flap back on, right? You save it on the back end. So I think it's worth getting comfortable and used to endoscopic evacuation. And really, that's going to be your tool for basal ganglia hemorrhages, which is a lot of what I see. The lower stuff is easy to do, right? It's a chip shot to stick an endoscope. It's the basal ganglia stuff that are problematic. And I think getting good at endoscopy helps you treat those patients.
You mentioned a couple of cases now. For these patients who have already a midline shift, are you still doing endoscopic, or is still your practice in general, so the hemicranie and then wait?
Right. So very much depends. Let's say somebody comes in with a big venous infarct, a big amyloid angiopathy, or something big and lobar. I'll either do open surgery, right, for lobars, or I may just do decompression. For deep stuff, wherever I can, I'm going to use endoscope.
Okay. Even when even in extremis, when somebody's like they're calling you, hey, the patient is now altered, not waking up, blown pupil,
So I'll give you an example, right? Let's say somebody comes in, again, we're talking deep basal gangliar hemorrhages
right.
with a large blown pupil. A lot of places may not even treat that. Let's say you want to treat it, right? So you're going to bring in, what are you going to do for that? You could do a decompressive hemicraniectomy, which is what Switch showed, right?
Hmm.
But
Hmm.
think of it, you're going to bring the patient in, you may or may not pin, you're going to have to swing a large trauma flap, fold it over, do a big craniotomy, open the dura. So how much time has passed?
45 minutes at least.
Okay. All right. So I'm going to go there, pin the patient, quickly nav it, do a teeny incision, do a burr hole, get the endoscope in, and start suctioning.
I
How
see.
much time has passed?
Yeah. Yeah. Yeah.
You
It's
can't
just
tell me it's that much slower, right?
no, it's not. I think it's a matter of comfort. When you've done it, you've seen it a couple of times that okay, because obviously we're all, you have blown pupil, take the bone off, decompress. That's
Okay.
it's
Blonde
almost
people quickly get in there, do a teeny
yeah.
hole, get into the clot faster, and start suctioning.
Yeah. I think
The
that's
key is, though,
definitely yeah.
that's why the more you do
Hmm.
endoscopic evacuations, the more, and it's not just your comfort level, right? We all, think we're surgical prima donnas and the world revolves around us, right? I'm going to save the world. That's not how it is. Surgery is the ultimate team sport. People forget about that, right? It's you, it's your resident, it's the scrub nurse, it's the scrub dick, it's anesthesia, it's the anesthesia resident, it's everyone. It's the ultimate team sport. You may be
Yeah.
the captain trying to lead the team, but you have to be comfortable at 2 in the morning, but so has to be your nurses, your techs. They need to know where to get the equipment, the navigation system, anesthesia, the ED. The more you do this, the more people get comfortable, the more your team can support you and the patient, the better it's going to be.
Yeah.
So that's why we try to do more of one thing. The more of one thing you do, the more you and your team get better at it.
Yeah. Well, we're coming into the end of the hour. Thank you so much. This was a phenomenal talk, and it brought me back to the residency days of all the teachings.
We miss you, Rudy.
Uh, thank you. This was truly phenomenal. I appreciate you giving us such a phenomenal talk and taking the whole hour. This again, I hope everybody heard that message because I agree. Everywhere it's just there's a lot of hesitancy to open up that hemorrhage, the hemorrhagic strokes into a surgical disease, not just medical disease. So hopefully the message resonates with everybody, and then we can actually move forward with that, just like we did in 2015 after and for ischemic
Correct.
strokes.
Correct. If we could do it for ischemic, it is our moral and ethical duty. We need to enroll into trials. If we don't do it, who's going to do it?
Yeah,
Right?
absolutely,
So
absolutely.
with that, please, if there's anything I do to help you guys, if I can encourage you to enroll in trials, let me know. And it's been a pleasure catching up. Thank you so much for the invite.
We'll absolutely be in touch. Thank you,
All
Dr.
right.
Jerome. Thank
Bye
you,
bye.
everyone.